Welcome back to the deep dive. We're taking your sources, pulling out the core insights, getting you up to speed fast. Today, wow, it's a big one. We're tackling two huge pharmacological areas, gastrointestinal or GI, pharmacology, and exogenous hormone therapy.
Yeah, it's quite the stack. They seem, pretty separate on the surface.
Right, stomach stuff on one hand, hormones on the other.
But they're both fundamentally about how the body keeps things in balance, these incredibly delicate internal systems.
Exactly, from stomach acid, which is super aggressive, to hormone signals, which are, well, much more subtle but system-wide.
It really is a massive amount of material to synthesize. And complexity, that's the key word here. Whether we're talking about protecting the stomach lining or, adjusting the endocrine system with drugs, these are powerful agents.
They really influence that internal equilibrium.
Profoundly. So our job is to figure out not just what they are, but how they work, and critically, where the hidden dangers might be lurking.
So that's our mission today. A clear, structured shortcut through all this. We want to pull out the core mechanisms, the main uses, and the absolute must-know safety alerts. Basically, science behind the scripts, right? So you walk away really understanding it. Let's dive straight in, starting with the GI tract. Okay, first things first, we need to know what we're treating. Let's start with peptic ulcer disease, PUD. What's actually happening there, like at the tissue level?
Okay, so PUD, it's basically a deep sore and erosion that goes right through the mucosal lining into the layer beneath the submucosa. And the core problem is this constant battle, this imbalance between defensive factors and aggressive factors.
Defensive factors, what are those?
That's the body's natural protection. Things like mucus, bicarbonate, which neutralizes acid, good blood flow to the tissue, and these protective molecules called prostaglandins.
Okay, so that's the defense. What's the attack? What are the aggressive factors trying to break through?
Primarily four big ones. First, this bacteria, Helicobacter pylori, or H. pylori. That's the main cause worldwide. Then you've got chronic use of NSAIDs, like ibuprofen and naproxen. And, of course, the stomach's own gastric acid and pepsin, which is an enzyme that digests protein.
So H. pylori is the big one. How does it cause ulcers?
Yeah, when H. pylori sets up shop in the stomach, it basically weakens those defenses. It can mess with the mucus layer, reduce bicarbonate, makes the lining vulnerable.
So it's not always just too much acid then. It can be the defenses failing.
Exactly. Often triggered by that bacterial invader, H. pylori.
What about risk factors? Besides H. pylori and NSAIDs, what else makes PD more likely?
Well, smoking is a big one. Also, things that reduce bicarbonate production or maybe increase acid. Chronic stress and anxiety seem to play a role too.
Interesting. Now, what about diet? I always thought spicy food or alcohol caused ulcers.
Yeah, that's a common belief, but the source material is actually pretty clear on this. While certain foods and alcohol can definitely irritate an existing ulcer or cause heartburn, they haven't been consistently shown to be a primary cause of PU itself.
Huh. That's a really important distinction, especially when talking to patients.
Huh.
Okay, let's pivot to GERD. Gastroesophageal reflux disease. Also involves acid, but it's different, right?
Totally different mechanism. GERD is what gives you that classic heartburn, the regurgitation feeling. It can range from just symptoms, what we call non-erosive reflux, to actual damage, erosive esophagitis. The root cause here is mechanical. It's the valve between the esophagus and the stomach, the lower esophageal sphincter, or LES.
It relaxes when it shouldn't.
Exactly. It relaxes inappropriately, transiently, allowing the stomach contents, including acid, to splash back up into the esophagus.
Crucially, H. pylori isn't involved here.
Nope. H. pylori is not associated with causing GERD. That's a key difference from PU.
So, PUD. Often infection-driven breakdown. GERD, more of a mechanical valve issue. Treatment for both involves lowering acid. But GERD management isn't just about drugs, is it?
Not at all. Lifestyle changes are absolutely fundamental for GERD. They should be the first thing you try.
Like what?
The list is pretty standard but effective. Stop smoking, lose weight if needed, cut back on alcohol, avoid eating late at night, and physically elevating the head of the bed is important. We're talking 6-inch blocks under the bedposts or using a wedge pillow.
Not just stacking pillows.
No, stacking pillows can actually make it worse because it bends you at the waist and increases pressure. Also, avoiding specific trigger foods, caffeine, chocolate, fatty foods that varies person to person.
Right. Since H. pylori is the main villain in PUD, let's talk about getting rid of it. You can't just use one antibiotic, can you?
No way. That bacteria is tough, and resistance is a huge issue. To really knock out H. pylori, the guidelines call for combination therapy. It's usually a 10 to 14-day course involving at least 2, but ideally 3, different antibiotics.
Which ones are common?
Things like amoxicillin, clarithromycin, metronidazole, tetracycline, maybe bismuth, which is in Pepto-Bismol, or tinidazole.
Okay, multiple antibiotics.
Mm.
But you also have to add an acid-suppressing drug, right?
Yeah.
A PPI or an H2RA. Why is that essential?
That's a great point. It's mandatory because the antibiotics just work much, much better when the stomach isn't so acidic. Raising the pH makes the bacteria more vulnerable to the drugs. Plus, it creates a better environment for the stomach lining to actually heal itself once the bacteria are gone. It's synergistic.
Got it. So let's talk about those acid suppressors. Starting with the older class, the histamine 2 receptor antagonists, H2RAs.
Right. These block H2 receptors on stomach cells, which reduces how much acid is secreted and makes it less acidic overall.
And the first one was a blockbuster drug, wasn't it?
Oh, yeah. Cimetidine, brand name Tagmet, came out in '77, revolutionized ulcer treatment. For a while, it was the #1 prescribed drug in the world.
Wow. But they're not used as much now.
They're still used, especially for milder GERD or occasional heartburn. Famotidine, Pepcid, Nizatidine, Axid. But yeah, compared to the next class we'll talk about, all the H2RAs are generally less potent, less effective for serious acid suppression.
And Zitidine specifically had some unique side effects and interactions.
It did. It's kind of the odd one out in the class. It has this known anti-androgenic effect.
Anti-androgen, like blocks male hormones.
Sort of. It's thought to cross into the brain more easily and maybe interfere with hormone receptors or how they're metabolized. Clinically, especially with high doses or long use, it could cause things like gynecomastia, breast enlargement in men, or reduced libido.
That's pretty significant. And the drug interactions.
Notorious. Cimetidine messes with liver enzymes that break down other drugs.
Hmm.
So it can cause levels of really important medications to shoot up, like warfarin, the blood thinner, phenytoin for seizures, theophylline for asthma, even lidocaine. That can dangerous.
And even simple antacids can interfere.
Yeah, antacids can decrease how well cimetidine is absorbed, so you have to space them out. Oh, and there's a class effect, too. By reducing stomach acid, all H2RAs slightly increase the risk of pneumonia. Less acid means fewer defenses against bugs getting into the lungs.
Right, okay. Now let's move to the current champions of acid suppression. The proton pump inhibitors, PPIs, omeprazole, pantoprazole.
Mm.
Why did these take over?
Pure efficiency, really. PPIs are the drugs of choice because they work faster, often within a couple of hours, and their effect lasts way longer days, even weeks sometimes.
How do they work differently?
Think of the proton pump as a tiny motor in the stomach wall cells that churns out acid. H2RAs kind of turn down the motor's speed. PPIs, though, they irreversibly block that motor. They basically shut it down completely. The cell has to physically make a new pump to start producing acid again at full strength.
Irreversibly. Wow, that explains the power. So they're used for more severe stuff.
Yeah, severe GERD, gastric and duodenal ulcers, conditions where the stomach makes way too much acid.
How long do people usually take them?
Well, the goal is usually short-term, like 6 to 12 weeks for typical ulcer healing. The sources really emphasize using them for the shortest time necessary, but for some chronic issues, like maybe a large hiatal hernia or severe Barrett's esophagus, some people might need to be on them for years, even decades. It's always a risk-benefit calculation.
And that brings us to the risks of long-term use. What are the main concerns?
Okay, common things are headache, diarrhea. We mentioned pneumonia risk, similar to H2RAs. There's also an increased risk of fractures, probably because less acid means less calcium absorption, and low magnesium levels, hypomagnesemia.
But there's one really big safety alert.
Yes, the non-negotiable one. Clostridium difficile infection, C. diff.
How do PPIs increase that risk?
By changing the stomach's pH so drastically, they disrupt the normal gut bacteria, the microbiome. This makes the gut much more vulnerable to C. diff taking hold if you get exposed, and C. diff can cause severe, potentially fatal colitis.
So someone on a PPI gets diarrhea.
They need to report it immediately. High index of suspicion for C. diff. It's a really clear example of how a very effective drug can mess with the body's natural balance.
You mentioned pantoprazole, or Protonix, is used a lot in the ICU.
Yeah, very common. Often given IV to prevent stress ulcers in really sick patients, people in shock or on ventilators.
And the practical tip.
As soon as the patient can swallow pills, switch them from IV to PO, the oral form. Saves money, less risk than an IV line.
Okay, beyond the main acid suppressors, there are other agents. What about sucralfate, carafate? It works differently, right? Creates a barrier.
Totally unique mechanism. Sucralfate is approved for duodenal ulcers. When it hits the acidic stomach environment, it polymerizes, basically turns into this sticky, paste-like substance. It then selectively binds to the ulcer crater, forming a protective barrier over it. Shields it from acid and pepsin for about 6 hours, letting it heal underneath.
And the tricky part is how it works affects when you give it.
Exactly. Key points. Sucralfate does not neutralize acid, and it does not reduce acid secretion. But, and this is crucial, it needs an acidic environment, pH below 4, to activate and form that sticky barrier.
So you can't give it with antacids or PPIs.
Right, you have to separate them. Give sucralfate first, wait at least 30 minutes before antacids, maybe longer for PPI H2RAs, depending on timing. And because it coats things, it can physically block the absorption of other drugs.
So what's the rule for other meds?
Don't give any other oral meds within 30 minutes of sucralfate. And for certain critical drugs, anitoin, theophylline, digoxin, warfarin, fluoroquinolone, antibiotics, you need a bigger window, at least 2 hours, to make sure they get absorbed properly.
Side effects?
Mostly just constipation because it's not really absorbed into the body.
Okay, next up, misoprostol. A prostaglandin E1 analog. What's its specific niche?
Misoprostol is primarily for one thing, preventing gastric ulcers in people taking long-term NSAIDs, especially high-risk folks like the elderly. It mimics the body's natural prostaglandins, it helps reduce acid a bit, but more importantly, it boosts the secretion of protective mucus and bicarbonate.
But it comes with a huge warning related to pregnancy.
Massive warning. Misoprostol is pregnancy category X, absolutely contraindicated in pregnancy.
Why?
Those same prostaglandin effects that protect the stomach also cause strong uterine contractions. It's actually used, often with another drug, mifepristone, to induce medical abortions. So using it in any woman who could potentially become pregnant requires extreme caution and reliable contraception. It's a stark reminder of how potent these effects are.
Wow. Okay, finally, the oldest group, antacids. Simple neutralizers.
Yep, basic chemistry. They use alkaline compounds, magnesium, aluminum, calcium, sodium-based, to directly neutralize stomach acid. They also reduce the activity of pepsin and might stimulate those protective prostaglandins a bit.
How should they be taken for ulcer treatment?
The classic dosing is frequent,
Yeah.
usually 1 and 3 hours after each meal, and again at bedtime, to keep the acid neutralized.
And managing their side effects. Aluminum versus magnesium.
Right, aluminum tends to cause constipation. Magnesium tends to cause diarrhea. That's why you often see combination products like Maalox or Mylanta. They try to balance out the bowel effect.
The other cautions.
Watch out for the sodium content in some antacids, especially for patients with high blood pressure or heart failure. And like sucralfate, they can interfere with the absorption of other drugs, so timing matters. Separate them from things like cimetidine or sucralfate.
All right, shifting gears from acid to movement, let's talk laxatives briefly. What are the main types?
We usually classify them by how they work. You've got bulk foaming ones like fiber supplements, surfactants like docusate, which are stool softeners, stimulants like bisacodil that make the intestines contract more, and osmotics like lactulose or magnesium citrate that draw water into the bowel.
When are they used?
Obvious one is constipation, also used to empty the bowel before surgery or procedures, and sometimes to counteract constipation caused by other drugs like opioids.
When should you absolutely not use them?
Big red flags. Never give a laxative if the person has undiagnosed abdominal pain, severe cramps, signs of an acute abdomen, or if you suspect a fecal impaction or bowel obstruction, you could cause a perforation.
Let's spend a minute on laxative abuse. It seems like a common problem. Why does it happen?
It's often driven by misconceptions. There's this persistent, often heavily marketed idea that you must have a bowel movement every single day to be healthy, which just isn't true for everyone. It's also, unfortunately, sometimes linked with eating disorders.
What does chronic abuse do to the body?
It really messes up your natural bowel habits. Over time, especially with stimulants, the bowel can become dependent. The natural defecatory reflexes get weaker, so you need the laxative just to go. It's a vicious cycle.
And other physical problems, too.
Oh, yeah. Chronic use can lead to serious fluid and electrolyte imbalances, dehydration, low potassium. It can even cause a type of colitis. The colon basically forgets how to work on its own.
So treatment isn't just stopping the laxative.
No, it's more involved. Obviously, stopping the drug is key. But then it's intensive education, encouraging fluids, fiber, exercise, and critically, bowel retraining, establishing a regular time to try and go, focusing on the quality of the stool, soft, easy to pass, not the frequency or amount. It's about breaking both the physical and psychological dependence.
Okay, let's flick to the opposite problem. Nausea and vomiting, antiemetics. The first-line drugs are often the serotonin receptor antagonists, like ondansetron, Zofran.
Yes, ondansetron is very effective. Main uses are for nausea caused by chemotherapy, radiation therapy, anesthesia after surgery, and also for severe nausea and vomiting in pregnancy. It works by blocking specific serotonin receptors, type 3 or 5-HT3 receptors, both in the gut and in the brain's chemoreceptor trigger zone, the CTZ.
Is it often used alone?
It can be, but especially for chemo-induced nausea, it's often combined with a corticosteroid like dexamethasone. That combination works much better than either drug by itself.
What's the major safety warning with ondansetron?
The big one is cardiac. Ondansetron can prolong the QT interval on an electrocardiogram, an EKG.
And why is that dangerous?
A prolonged QT interval increases the risk of a specific, dangerous type of irregular heartbeat called torsades de pointe. It's a form of ventricular tachycardia that can be fatal, so you have to be really careful using it in people who already have heart issues like heart failure, low potassium or magnesium levels, or a slow heart rate.
Okay, moving to another class. The dopamine antagonists.
Yeah.
Phenothiazines, metoclopramide. Different target.
Yeah, these work primarily by blocking dopamine receptors, specifically D2 receptors in that same chemoreceptor trigger zone in the brain. They're used for various types of nausea and vomiting, but they come with a different set of potential side effects.
Like what?
More neurological stuff. Extrapyramidal reactions, think movement problems like tremors or stiffness. Also, anticholinergic effects like dry mouth, blurry vision, constipation. Plus, hypotension and sedation, they can make you quite sleepy.
And one of them, promethazine, has a particularly serious warning.
It does. Promethazine carries a black box warning about the risk of severe respiratory depression, especially dangerous in young children, and also risk of really bad local tissue injury, even gangrene if it's injected improperly, especially into an artery or under the skin instead of deep muscle, needs extreme care.
Let's single out metoclopramide, Reglan. It's called a prokinetic agent. What's special about it?
It does double duty. It blocks dopamine receptors to suppress nausea, and it increases upper GI motility. It helps the stomach empty faster and tightens the LES a bit.
So it's good for...
Great for GRD because it helps clear acid out of the esophagus. Also used for diabetic gastroparesis. That's when diabetes damages the nerves controlling the stomach, so it empties really slowly. And sometimes used for nausea, vomiting, and pregnancy, too.
But it has a significant long-term risk, especially in older adults.
Yes. The major concern with long-term metoclopramide use is tardive dyskinesia.
What's that?
It's a potentially irreversible movement disorder, causes involuntary repetitive movements, often of the face, tongue, or limbs. The risk goes up the longer you take it and is higher in the elderly. So the advice is usually to give it about 30 minutes before meals or chemo and keep the duration of therapy as short as absolutely possible.
Lastly, for this section, motion sickness. How do those drugs work?
Motion sickness drugs target the signals coming from the inner ear's vestibular system to the brain's vomiting center. Scopolamine is a classic one. It's a muscarinic antagonist. Antihistamines like meclizine or dimenhydrinate also work, blocking both histamine and muscarinic receptors involved in that pathway.
Side effects are similar.
Yeah, because they both have that anticholinergic action. Common side effects are dry mouth, blurred vision, drowsiness, sedation.
Okay, the GI tract can also get really inflamed. Conditions like inflammatory bowel disease, IBD Crohn's, and ulcerative colitis. How are those managed?
IBD treatment is usually a step-up approach. You start with milder drugs and escalate if needed. First line often involves 5-aminosalicylates, like sulfasalazine or mesalamine. These work locally in the gut to reduce inflammation. An important note from the sources. Sulfasalazine seems to be safe during pregnancy and breastfeeding.
What comes next if those aren't enough?
Then you might move to glucocorticoids, like prednisone for flares. For longer-term control or more severe disease, you use traditional immunosuppressants like azathioprine or mercaptopurine, the thiopurines, and then the most potent agents are the immunomodulators, often called biologics.
Infliximab is a key immunomodulator. How does it work, and what's the big risk?
Infliximab is a monoclonal antibody. It specifically targets and blocks tumor necrosis factor alpha, or TNF-alpha, which is a major chemical messenger driving inflammation in IBD. It can be very effective, often used first line to get severe disease into remission, or for complications like fistulas and Crohn's disease, but because it powerfully suppresses the immune system.
Big infection risk.
Huge infection risk. Patients are vulnerable to serious, sometimes life-threatening infections. Bacterial sepsis, reactivation of dormant tuberculosis or hepatitis B, invasive fungal infections. It's a major safety alert. Any sign of infection needs immediate attention.
Okay, let's switch to irritable bowel syndrome, IBS. Different from IBD, right? More about symptoms.
Right. IBS doesn't involve the same kind of deep inflammation or damage as IBD. It's considered a functional disorder diagnosed by symptoms like pain, bloating, and altered bowel habits, either diarrhea predominant, IBSD, or constipation predominant, IBSC.
Are there specific drugs approved just for IBS?
Yes, there are a few targeted therapies. For IBSC, there's lubiprostone and linaclotide. For severe IBSD, primarily in women, there's elustron.
Elestron. I remember reading that one has some really strict safety rules around.
Extremely strict. Elustron is only for women with severe IBSD lasting more than 6 months who haven't responded to anything else.
Why such tight restrictions?
Because it can cause rare but potentially fatal gastrointestinal problems. The main concerns are severe constipation that can lead to bowel obstruction or impaction and ischemic colitis.
Ischemic colitis, lack of blood flow to the colon.
Exactly. Reduced blood flow can damage or kill parts of the bowel wall. Because of these risks, Elustron requires enrollment in a special risk management program. Both the doctor and the patient have to sign an agreement.
What does the agreement cover?
It confirms the patient understands the risks, knows the warning signs like worsening constipation, bloody diarrhea, new or worsening abdominal pain, and agrees to stop the drug immediately and call their doctor if any of those occur. It's a necessary precaution due to the potential severity.
Wow. Okay, one last specific GI drug, palifermin or Kepivance, for oral mucositis.
Yeah, this one's interesting. Palifermin was the first drug specifically approved to treat or prevent severe oral mucositis, those incredibly painful sores in the mouth that are a common side effect of high-dose chemotherapy. It's a synthetic version of a natural protein called keratinocyte growth factor, which helps skin and lining cells grow.
Is it used for all chemo patients?
No, its approval is very narrow. It's only indicated for patients with blood cancers, hematological malignancies who are undergoing high-dose chemotherapy, and total body radiation before getting a hematopoietic stem cell transplant.
And there's a critical timing issue with giving it.
Absolutely critical. You have to give palifermin either 24 hours before starting the chemoradiation or wait until 24 hours after it's finished.
Why?
Because if you give it during the chemo, the drug makes the mucosal cells grow faster, which could actually make them more sensitive to the damaging effects of the chemo, potentially worsening the mucositis. Timing is everything with this one.
That really drives home the theme, doesn't it? Even helpful drugs can backfire if not used precisely right. Seems like a good place to pivot from the GI tract. Let's move into the endocrine system and hormone therapy. Okay, before we talk about giving hormones as drugs, we need a quick refresher on the body's own, the endogenous hormones. So are the estrogens.
Right. Estrogens are steroid hormones. In females, the main production sites are the ovaries, especially during the first half of the menstrual cycle, the follicular phase, and also the placenta during pregnancy. Estradiol is the most potent form during the reproductive years. After menopause, other forms like estriol and estrone become more dominant, though less potent.
What about in males? Do men have estrogen?
They do, yeah. Testosterone can be converted into estriol and estrone in smaller amounts, but those amounts are physiologically important. Estrogens work by binding to specific nuclear receptors called ER-alpha and ER-beta. These receptors are found all over the body: uterus, bones, brain, heart and blood vessels, mammary glands.
So their effects are widespread. What are the key things estrogen does?
Physiologically, it's crucial for developing and maintaining the female reproductive system and for breast development, specifically the ducts. Metabolically, it's generally protective. It promotes bone density, which is why osteoporosis risk goes up after menopause. It has positive effects on cholesterol levels, helps regulate blood sugar, and even seems to have neuroprotective effects in the brain.
Okay, now progestins. Where do they come from?
Progestins, with progesterone being the main one, are produced primarily by the corpus luteum. That's what's left in the ovary after ovulation during the second half of the cycle, the luteal phase. And like estrogen, the placenta makes a lot during pregnancy.
What are their main jobs?
Their big role is preparing the uterus for pregnancy. They make the uterine lining, the endometrium, thicken and become receptive to implantation. They also make the cervical mucus thick and scanty, which kind of seals off the uterus.
I remember hearing they affect body temperature, too.
Yep, that slight rise in basal body temperature after ovulation, that's progesterone. It also has effects on the central nervous system, can cause sleepiness, sometimes depression in sensitive individuals.
And critical for pregnancy itself.
Absolutely essential. Progesterone keeps the uterine muscle relaxed, preventing contractions. It also contributes to that decreased GI motility we sometimes see in pregnancy, leading to constipation.
Got it. Finally, the androgens. Testosterone is the main one, right?
Testosterone is the principal androgen. In males, it's made mainly in the testes. Females also produce androgens, but in smaller amounts, mostly by converting precursor hormones in the ovaries and adrenal glands.
What do androgens do? Obviously important for male development.
Yeah, they drive male puberty and maintain male characteristics. But they have important effects in both sexes. They have a strong anabolic effect, building muscle and bone mass. They also stimulate the production of red blood cells. That's the erythropoietic effect. In females, androgens contribute to libido and the health of some reproductive structures.
Okay, foundation laid. Now, how do we use these hormones, starting with exogenous estrogens, as medications? What are the non-contraceptive uses?
Probably the most common use is menopausal hormone therapy, MHT, to manage symptoms like hot flashes. Also used to treat female hypogonadism, where the ovaries don't produce enough estrogen naturally. Other uses include treating severe acne, sometimes as palliative therapy for certain advanced cancers like breast or prostate cancer, and it's a key component of hormone therapy for transgender women.
How are they given?
Lots of ways. Orally, transdermal patches or gels, vaginal creams or rings. Depends on what you're treating. Systemic effects versus local effects.
Now, the risks. Estrogen therapy isn't without significant dangers, especially cancer-related.
Absolutely. This is a huge safety consideration, the biggest one. If you give estrogen alone, we call that unopposed estrogen to a woman who still has her uterus. It causes the uterine lining, the endometrium, to keep growing and thickening. This dramatically increases the risk of endometrial hyperplasia, which can lead to endometrial cancer.
So unopposed estrogen is a major no-no if you have a uterus. What other risks?
Also increases the risk of certain types of breast cancer, particularly with long-term use. Risk of blood clots, DVT, pulmonary embolism, stroke, heart attack is elevated, and risk of gallbladder disease goes up too.
So who should definitely not take estrogen therapy?
The contraindications are pretty strict. Anyone with a history of blood clots like DVT or PE or heart attack or stroke, active liver disease, known or suspected estrogen-dependent cancer like breast cancer, undiagnosed abnormal vaginal bleeding, and obviously pregnancy.
And there's even a hazard alert for healthcare workers.
Yes, NOH, the National Institute for Occupational Safety and Health, classifies estrogens as hazardous drugs. Healthcare workers handling them, even topical forms, need to use specific precautions, like gloves, to avoid absorption.
That really highlights the potency.
Yeah.
Okay, this leads perfectly into progestins because they're often used with estrogen, specifically to counter that endometrial cancer risk.
Exactly. That's a primary non-contraceptive use. Add a progestin to estrogen therapy for any woman with a uterus to protect the endometrium. Other uses include treating dysfunctional uterine bleeding, managing amenorrhea, lack of periods, and sometimes used to try and prevent premature birth, though the data there is complex.
Let's talk specifically about menopausal hormone therapy, MHT. The thinking on this has changed dramatically over the years, hasn't it?
Oh, completely. The current mantra, based on large studies like the Women's Health Initiative, WHI, is critical. Use the lowest effective dose for the shortest possible duration needed to manage symptoms.
And it can be estrogen alone or combined.
Right. Estrogen only, MHT, if the woman has had a hysterectomy. Combined estrogen-progestin therapy if she still has her uterus.
What are the currently approved reasons to use MHT?
There are basically three main approved indications. One, managing moderate to severe vasomotor symptoms, that's hot flashes and night sweats. Two, treating moderate to severe symptoms of vulvar and vaginal atrophy dryness, itching, pain with intercourse. For this, topical vaginal estrogen is usually recommended first to minimize systemic exposure. And three, prevention of postmenopausal osteoporosis. Though usually other drugs are preferred first line for osteoporosis prevention if the woman doesn't also have vasomotor symptoms.
Okay, but what MHT is not used for anymore? This was the big shift from the WHI trials, right? Preventing heart disease or dementia.
Exactly. That was the paradigm shift. Before WHI, there was observational data suggesting estrogen might protect the heart. But the WHI randomized trials, especially when started in older women, actually showed a small increase in the risk of stroke, blood clots, and even heart attacks in some groups on combined MHT. And it didn't prevent cognitive decline or dementia. Some data even hinted at increased risk.
So the conclusion was clear.
Definitive. MHT should not be initiated or continued for the primary purpose of preventing cardiovascular disease or dementia. The risks outweigh potential benefits for those indications.
Which brings us back to that fundamental rule for prescribing.
Cannot emphasize this enough. Women with the uterus must receive a progestin along with estrogen if they're getting systemic therapy. Women without a uterus should receive estrogen only. Adding a progestin in that case just adds potential risks, like breast cancer risk, without any benefit.
Makes sense.
Yeah.
Okay, let's talk contraception now, starting with the most common, combined oral contraceptives, COCs, or the pill.
COCs contain a synthetic estrogen, usually ethinyl estradiol, plus one of many different types of progestins. The goal is always to use the formulation with the lowest effective dose of estrogen to minimize side effects and risks.
How do they work?
It's a multi-pronged approach. They primarily work by suppressing ovulation, preventing the ovaries from releasing an egg. They also thicken the cervical mucus, making it harder for sperm to get through. And they alter the uterine lining, making it less suitable for implantation just in case ovulation somehow still occurs.
Who absolutely should not use COCs? What are the absolute contraindications?
The big ones relate mostly to blood clot risk, so smokers over the age of 35, anyone with a current or past history of DVT, PE, stroke, or heart attack, certain heart valve problems, also known or suspected breast cancer or other estrogen or progestin-sensitive cancer, liver tumors or active liver disease, undiagnosed abnormal uterine bleeding, and confirmed or suspected pregnancy.
Besides preventing pregnancy, COCs actually have some significant health benefits, don't they?
They do, quite a few actually. They significantly decrease the lifetime risk of both ovarian cancer and endometrial cancer. They lower the risk of pelvic inflammatory disease, PID, and reduce the formation of benign ovarian cysts. Plus, they often make periods lighter, shorter, more regular, and less painful, which can be a huge quality of life improvement and help with conditions like iron deficiency anemia or endometriosis.
Side effects often mimic pregnancy or hormone imbalances. How can you tell if a side effect is due to too much estrogen or too much progestin?
Yeah, you look at the pattern. Signs of estrogen excess often include nausea, breast tenderness, bloating, or edema, maybe mild elevations in blood pressure. Estrogen deficiency might cause early or mid-cycle breakthrough bleeding or spotting. Signs of progestin excess can include increased appetite, weight gain, fatigue, mood changes like depression, sometimes acne. Progestin deficiency might lead to late breakthrough bleeding.
So you can sometimes fix side effects by switching to a pill with a different hormone balance.
Exactly. Adjusting the type or dose of the progestin or the estrogen dose can often resolve those issues.
Do COCs interact with other medications?
Yes, important interactions. Some drugs, particularly certain anti-seizure medications like phenytoin or carbamazepine, the antibiotic rifampin, and even the herbal supplement St. John's wort, can induce liver enzymes that break down the hormones in the pill faster. This can potentially reduce the effectiveness of the COC and lead to unintended pregnancy. Backup contraception might be needed. Conversely, COCs can sometimes inhibit the metabolism of other drugs, like theophylline or some antidepressants, potentially increasing their levels and side effects.
Okay, let's move to the long-acting reversible contraceptives, LARCs. The sources highlight these as the most effective methods available.
By far. Their effectiveness rates are incredibly high, mainly because they remove the factor of user error. Once they're in place, they just work.
What falls under the LARC category?
You've got the subdermal implant, like Nexblend, a small rod placed under the skin of the upper arm, releasing progestin for up to 3 years. There's the injectable progestin, Depo-Provera, given as a shot every 3 months. And then the intrauterine devices, IUDs. There are hormonal IUDs like Mirena, Skyla, Liletta, releasing progestin locally for 3 to 5 years or more, and the non-hormonal copper IUD.
Their effectiveness is really top tier then.
Absolutely. Failure rates are extremely low, comparable to sterilization, but they're completely reversible. They're recommended as first-line options for most women by major medical organizations.
And a quick word on emergency contraception, EC.
Right. Options if regular contraception fails or wasn't used. There are EC pills, levonorgestrel pills, like Plan B, are most effective within 72 hours, 3 days. Ulipristal acetate, ELA, works up to 120 hours, 5 days, but needs prescription. But the most effective form of emergency contraception is actually the copper IUD. If inserted within 5 days of unprotected intercourse, it's over 99.9% effective at preventing pregnancy, mainly by preventing implantation.
Good to know. Okay, final category, exogenous androgens. Using testosterone or similar compounds as therapy. What are the main uses?
Primary use is treating male hypogonadism when the testes don't produce enough testosterone. Also used to induce puberty in cases of significant delay. Sometimes used off-label in postmenopausal women for severe low libido that hasn't responded to other treatments. Can be used as part of hormone therapy for transgender men. And because of their muscle-building anabolic effects, they're sometimes used to treat cachexia, severe muscle wasting, associated with chronic illnesses like AIDS or cancer and certain types of anemia, because they stimulate red blood cell production.
What are the major risks and side effects associated with androgen therapy?
Several significant ones. They can increase the risk of blood clots, thrombosis. They can be toxic to the liver, so liver function needs monitoring. They can worsen cholesterol profiles, lowering HDL, good cholesterol, and raising LDL, bad cholesterol. And a major concern in men is that they can potentially promote the growth of existing prostate cancer, so screening is important.
But perhaps the biggest day-to-day risk involves others in the household. The virilization warning.
Yes, this is critically important, especially with topical gels or patches, which are common now. Virilization means the development of male physical characteristics. If women or children come into contact with the medication on the man's skin, they can absorb it and develop effects like facial hair growth, deepening voice, clitoral enlargement in girls, or premature puberty in children.
So secondary exposure is a real danger.
Absolutely. There have been documented cases. Androgens are pregnancy category X, definitely harmful in pregnancy. So the nursing considerations and patient teaching are vital. Apply the gel patch to skin that will be covered by clothing. Wash hands thoroughly with soap and water immediately after applying. Wait for the application site to dry completely before letting skin contact others or clothing. Prevent children and partners from touching the application site. These precautions are essential to prevent accidental exposure. #tag outro. Well, we've certainly covered a lot of ground today. A really comprehensive synthesis, I think. We went from the stomach's acid defenses and bacterial invaders like H. pylori, needing careful combination therapy, all the way to the huge policy shifts around menopausal hormone therapy driven by the WHI trials, dictating exactly who gets what. The common thread, really, is navigating these complex biological systems, understanding balance, and appreciating how potent these drugs are for good and potentially for ill if not used carefully.
It really is high-stakes stuff. And fascinating how medical guidance evolves, isn't it? You mentioned cimetidine was number one, then PPIs took over. MHT guidance changed dramatically, it makes you think. PPIs are the standard now for long-term acid suppression, but we know about the C. diff risk, the fracture risk. They're not perfect. So here's a final thought for you, our listeners. What current drug of choice that seems indispensable today, maybe it is the PPIs, or perhaps the expensive biologic drugs for IBD we touched on. What do you think might be displaced by something newer, maybe more targeted or fundamentally safer in the next, say, 10 years?
That's a great question. Medicine never stands still. Always something new on the horizon.
Definitely something to ponder as you integrate all this into your thinking. Thanks for joining us for this deep dive. We'll be back soon to synthesize another stack of your sources.